You know the routine. You go to the doctor for a basic physical, you roll up your sleeve, and they wrap that classic Velcro cuff around your arm.
Right, the standard blood pressure check.
Exactly. You hear the pump whining, you feel the squeeze, and they read out a number. It is incredibly straightforward. It is loud, it is obvious, and it measures your systemic blood pressure.
Yeah, the pressure circulating through your entire body.
Right, so if the number is high, they tell you to, cut back on salt, maybe write you a prescription, and you just go on your way.
It's basically the pressure in the main plumbing of the house. I mean, systemic hypertension is something almost everyone is familiar with, but there is a completely different landscape inside your chest.
And that is exactly what we are looking at today, because deep inside the chest, there is a second, completely separate plumbing system.
Yeah, one that is practically invisible to that standard arm cuff.
Exactly.
Yeah.
And in this hidden system, a tiny, almost imperceptible shift in pressure isn't just a slightly elevated number on a chart. It actually becomes a devastating mechanical crisis for your heart.
We're talking about a silent pressure cooker hidden right in the lungs, a place where just a few extra millimeters of mercury can literally reshape the muscle of the heart itself.
Which leads to consequences that are incredibly severe. So welcome to today's deep dive. We have a massive stack of medical history, genetic research, and physiological data in front of us today.
It is a lot to get through.
It really is, and it is all centered around a fascinating but incredibly dangerous medical phenomenon called pulmonary hypertension.
Right.
Our mission today is to understand how a subtle shift in lung pressure essentially becomes a mechanical catastrophe for the heart.
And we really need to establish right up front that this is not just some rare textbook disease that you will never encounter. I mean, it is highly relevant.
It matters to you right now. Think about the world we live in today. We're seeing rising rates of obesity and obstructive sleep apnea.
Both massive factors.
Yeah, and we've seen significant cardiac strain in severe COVID-19 cases recently. Plus, there's this intense, renewed scrutiny on modern weight loss drugs.
Right, and the biological mechanisms behind pulmonary hypertension are tied into literally all of these modern health issues.
Which brings us to the foundational thesis of this deep dive.
Right, so pulmonary hypertension is typically thought of and, named as a lung issue. But its true clinical endpoint, and the thing that makes it so incredibly dangerous, is right heart failure.
So the lungs are where it starts, but the heart takes the hit.
Exactly. The lungs are the origin, but the heart is the one that pays the price.
Okay, let's unpack this. Because before we can even understand how that invisible pressure damages the heart, we have to look at how the medical community defines high pressure in the lungs in the first place.
Which is actually surprisingly complicated.
Yeah, looking through the sources, this is a number that has sparked a massive debate recently. How do doctors even measure this if they can't just use a cuff?
So they use a metric called mean pulmonary arterial pressure, or MPAP for short.
Okay, MPAP.
Right, and in a normal resting adult, that pressure is incredibly low. It is around 14 millimeters of mercury.
Wait, 14?
Yeah, just 14. To put that in perspective, your arm cuff reading is usually around 120 over 80.
Oh, wow. So the lungs are operating at a tiny fraction of that.
Exactly. The lungs operate at 14. And to get that precise number, doctors have to use the gold standard diagnostic tool, which is a right heart catheterization.
That sounds incredibly invasive. What does that actually entail for a patient?
I mean, it is a pretty intensive procedure. A cardiologist literally threads a catheter through a large vein, usually starting in the neck or the groin.
Ouch.
Yeah, and they navigate it up through the venous system, right into the right side of the beating heart, and then push it up into the pulmonary artery.
So they're measuring the pressure directly from the inside of the blood vessel.
Directly inside the pipes, yeah.
Wow. So 14 is the normal baseline. And for decades, the medical threshold to diagnose someone with pulmonary hypertension was a resting MPAP of 25 or higher.
Right. 25 was the magic number for a long time.
But then, in 2018, at the 6th World Symposium on Pulmonary Hypertension in Nice, France, they just changed the rules.
They dropped the threshold to anything greater than 20.
Just like that.
Yep, and this was formally adopted in 2022 by the major European cardiology and respiratory societies.
Why the sudden change, though?
Well, the rationale was deeply rooted in epidemiological data. Researchers looked at long-term patient outcomes and realized that individuals sitting in that 21 to 24 range—
The ones who were considered fine under the old rule.
Exactly. Those patients were already showing worse survival rates than people with the normal 14 pressure. The disease process had clearly already started.
But dropping that threshold overnight means suddenly a whole population of people who were previously considered completely normal are captured under a severe disease diagnosis.
So it's a huge shift.
Changing this threshold feels like the city suddenly lowering the speed limit from 25 to 20 overnight, and suddenly a whole demographic of normal drivers are now technically breaking the law.
That is an excellent way to conceptualize it. And that change sparked an intense debate in the medical community.
I can imagine.
Yeah, critics argued that we were risking over-medicalizing patients who just had, borderline hemodynamics. The real issue was that, at the time of the change, there was no specific drug therapy actually approved for that newly captured 21 to 24 group.
Oh, man. So you're giving someone a terrifying, life-altering diagnosis, and when they ask what the treatment is, you have to say you don't even have a specialized pill for them yet.
Exactly. The fear. It creates a lot of anxiety without a clear solution.
Right.
But the defenders of the new threshold argued that earlier recognition is literally everything in this disease.
Because it sneaks up on you.
Exactly. Even without a targeted drug, you can monitor them closely, catch the progression, and intervene with lifestyle or underlying disease management long before irreversible right heart damage sets in.
So both sides of the debate were purely focused on what was best for the patient, just coming at it from totally different angles.
Exactly. What's fascinating here is that the definition of pulmonary hypertension isn't just about that one single pressure number on a monitor.
Right. The sources point out that doctors also have to look at the resistance in the pipes, specifically something called pulmonary vascular resistance, or PVR.
Which is measured in Wood units.
Right, Wood units.
Yeah.
What is a Wood unit and why does it matter so much?
So think of a Wood unit as a measurement of friction or resistance to flow. It basically calculates how hard the heart has to push to get a specific volume of fluid through a specific size pipe.
Okay, that makes sense.
And for the most dangerous drug-treatable subtype of this disease, which is called pulmonary arterial hypertension, or PAH, the criteria actually require a PVR greater than 2 Wood units.
Because if you just have high pressure, it could be a completely different problem, right?
Exactly.
Like a garden hose.
Yeah.
If the pressure inside the hose is sky high, it could be because someone is actively stepping on the middle of the hose, clamping it down.
Right.
Or it could just be because the spigot of the house is turned up way too high and fluid is backing up from the source.
That resistance value is the smoking gun that tells you someone is stepping on the hose. It proves that the high pressure is being caused by narrow, diseased, small arteries within the lungs themselves.
So it's a localized problem.
Yes.
Yeah.
It's not just passive fluid backing up from a failing left side of the heart. You could have 2 patients with the exact same pressure reading of 25, but completely different resistance values.
Which means they have entirely different diseases.
And need completely different treatments, yeah.
So if the resistance in the pipes is the culprit, what actually happens to the pump? Because a pressure of 22 still sounds so incredibly small compared to the 120 in our arm.
It does seem small, yeah.
Why is that slight increase so catastrophic?
Looking at the sources, the answer seems to lie in the first principles of human evolution.
It really does. If we look at the basic architecture of the heart, the left ventricle and the right ventricle are practically 2 different organs in terms of how they're built.
Well, the left ventricle is a total powerhouse. It has a thick, muscular wall because it has to pump blood to the tips of your toes and the top of your head, pushing against the resistance of your entire systemic circulation.
It's the heavy lifter of the body.
Exactly. But the right ventricle, it only has to push blood right next door into the lungs.
Right, a very short trip.
And the pulmonary circuit evolved to be a low-pressure, highly compliant system. It's like a spongy network meant to accept blood really easily.
So it doesn't need to push hard.
No. So the right ventricle only needs to pump at about 25 millimeters of mercury systolic to get the job done. Because of that, evolution built the right ventricle to be this thin-walled, crescent-shaped muscle.
It sounds kind of fragile.
It is built to handle large volumes of blood, but it is absolutely not built to fight resistance.
So the lungs are the scene of the crime, but the heart is the actual victim.
That is a perfect way to put it.
But let me push back for a second. If the right ventricle is so thin and weak, why doesn't it just immediately give out the second the lung pressure spikes?
Because the body has an incredible capacity for adaptation, at least initially.
Right.
When the small pulmonary arteries in the lungs start to narrow, whether that's from vessels constricting, walls thickening, or blood clots, the right ventricle enters a compensatory phase.
It tries to fight back.
Just like lifting weights at the gym. When the muscle is forced to push harder against that new resistance, it physically thickens. This is called right ventricular hypertrophy.
But the sources describe pulmonary hypertension as a disease of mechanical exhaustion. So that muscle thickening isn't a permanent solution, is it?
Far from it. Eventually, the muscle just can't keep up. The blood vessels in the right ventricle itself literally can't supply enough oxygen to that overgrown muscle.
Oh, wow.
Yeah, so the right ventricle begins to dilate, the walls stretch out and become thin and incredibly weak.
And this is where the anatomy gets structurally terrifying. The sources talk about the interventricular septum, which is the wall separating the left and right sides of the heart.
Yep.
Normally, because the left side is so strong, that wall bows outward toward the right side. But under this intense lung pressure, it actually gets pushed flat, or even bows backward into the left side.
It literally crushes the left ventricle, essentially stealing its filling space. This end state is right heart failure, historically known as cor pulmonale, which is Latin for heart of the lungs.
Heart of the lungs.
Yeah. And when the pump fails, the blood has nowhere to go but backward into the body.
Which brings us to the human reality of this disease. What does that actually feel like for a patient going through it?
It is exhausting and deeply uncomfortable. Because the blood is backing up, fluid starts to leak into the tissues. Patients experience severe swelling in their legs and ankles.
Which is very visible.
Very. And fluid accumulates in the abdomen, a condition called ascites, making them feel constantly bloated and full. The veins in their neck become visibly distended.
Just from the backup of pressure.
Exactly. And because the left heart isn't getting enough blood to send out to the rest of the body, they experience profound fatigue and breathlessness just from, say, walking across a room.
The heart is essentially drowning in its own lack of forward momentum.
Yes.
To truly visualize the sheer mechanical force of this pressure, we don't just have to rely on catheter monitors. The sources point to some incredible concrete demonstrations of what this pressure physically does to blood flow.
The examples are wild.
Here's where it gets really interesting. Let's talk about Eisenmenger syndrome.
Oh, this is fascinating. This was first described way back in 1897 by Victor Eisenmenger. It actually starts with a congenital heart defect, a literal hole in the wall between the left and right sides of the heart.
Okay, so you're born with a hole.
Right. And because the left side operates at a much higher pressure naturally, blood initially flows left to right through that hole.
Okay.
This sends a massive abnormal volume of extra blood pounding straight into the lungs.
And over years, that constant high flow physically damages the delicate pulmonary vessels.
It just wrecks them.
The resistance in the lungs gets higher and higher, and eventually, the pressure on the right side of the heart overtakes the massive left side.
The pressure dynamics flip entirely.
It's like a river that gets so dammed up, it physically forces a waterfall to flow backward.
That is exactly what happens. The blood shunt reverses direction. It reverses to a right-to-left shunt.
Wow.
And the consequence of that is immediate. Deoxygenated blood from the right side of the heart is now bypassing the lungs completely.
Because it's taking the path of least resistance through the hole.
Yep. It shoots straight through the hole into the body's main systemic circulation. The patient physically turns blue, a condition known as cyanosis, because their tissues are being starved of oxygen.
It is a profound demonstration of how elevated pulmonary pressure can completely override the heart's normal mechanics.
It really is.
But we also see this pressure demonstrated environmentally, without any holes in the heart at all. In 1946, researchers von Euler and Liljestrand described high-altitude pulmonary hypertension.
The famous Euler-Liljestrand mechanism. This is a brilliant, but honestly sometimes flawed evolutionary quirk of human physiology.
How so?
Well, in most of your body, if a tissue is low on oxygen, the blood vessels dilate to bring more blood in.
Right. Open the roads to get more supplies.
Exactly. But in the lungs, it's the exact opposite. If a small pocket of your lung is poorly ventilated and low on oxygen, the vessels there actively constrict.
Which makes total sense locally. I mean,
Yeah.
you want to shunt blood away from the bad, diseased part of the lung and send it to the healthy parts where it can actually pick up oxygen.
It's a localized protective mechanism. It's smart.
Right.
But what happens if you climb a mountain? At high altitude, the air is thin. The entire lung is low on oxygen.
Oh, so the entire system panics.
Exactly. The entire pulmonary vascular bed constricts all at once. The protective mechanism breaks down and drives the pressure up globally across the entire chest.
And the sources note a really fascinating genetic twist here. Populations with long generational high-altitude adaptation, like Tibetans, actually have a blunted hypoxic vasoconstriction response.
Compared to, say, Andean populations who migrated to high altitudes much more recently.
Right. The Tibetans have a genetic adaptation linked to the EPS1 gene. It essentially tells their lungs not to panic and constrict in thin air, protecting their right heart from this exact pressure trap.
It's amazing. And you don't have to climb Everest to experience this mechanism.
No.
No, the same localized hypoxic constriction happens in people with obstructive sleep apnea.
Oh, wow.
You start breathing at night, your lungs get hypoxic, the vessels constrict, and you drive up that chronic pressure on the right side of your heart, literally night after night after night.
So natural hypoxia is one trigger. But we have also done this to ourselves chemically. Humans have inadvertently caused massive spikes in this disease through pharmaceuticals.
We really have.
The diet drug catastrophes completely shaped how the medical community classifies pulmonary hypertension today.
This is a dark but incredibly crucial chapter in medical history. In the 1960s, a diet drug, an appetite suppressant called aminorex fumarate, was marketed heavily in Switzerland, Austria, and West Germany.
And what happened?
Within just a few years of it hitting the market, the incidence of primary pulmonary hypertension in those countries rose roughly tenfold.
A tenfold increase in a rare, deadly disease, just from a diet pill.
Yeah, a physician named Walter Gertner linked the outbreak to the drug, and it was finally withdrawn in 1968.
Wow.
This epidemic was so severe, it directly triggered the first WHO-sponsored international symposium on the disease in 1973.
But we didn't learn the lesson.
Not at all.
Because in the 1990s in the United States, the diet drug combo fenfluramine and phentermine became wildly popular.
It was everywhere.
And in 1996, the New England Journal of Medicine published a study led by Lucien Ebenheim showing that using these appetite suppressants for more than 3 months was associated with a 23-fold increased risk of primary pulmonary hypertension.
It was Aminorex all over again, just a generation later with slightly different molecules.
How does a diet pill even destroy lung vessels? Like, what is the actual mechanism there?
It basically comes down to serotonin.
Serotonin. Like the brain chemical.
Exactly. These drugs were designed to increase serotonin levels in the brain, which suppresses appetite and makes you feel full. But serotonin doesn't just stay in the brain, it circulates in the blood.
Okay.
And in the pulmonary arteries, serotonin acts as a powerful growth factor. It literally signals the smooth muscle cells in the walls of the lung vessels to multiply.
Oh, so it builds them up.
Yes. The walls get incredibly thick, almost like a callus forming inside the pipe, narrowing the passage and driving the resistance sky high.
Those disasters forced the World Health Organization to organize the disease into 5 specific groups, mostly to clear up the misconception that pulmonary hypertension is just one single rare disease.
Which is a really common misunderstanding.
So group 1 is pulmonary arterial hypertension, or PAH. This is the rare direct vessel disease we just described, which includes the diet drug cases.
Right.
Group 3 is lung disease or hypoxia, like COPD or the sleep apnea we mentioned. Group 4 is from unresolved blood clots, known as CTEP.
Yep.
Group 5 covers unclear or multifactorial mechanisms. But Group 2 is pulmonary hypertension due to left heart disease.
And this is a vital point from the sources. Group 2 is actually the most common cause of pulmonary hypertension overall.
Wait, so the most common cause of high pressure in the lungs is actually just ordinary left heart disease?
Yes, absolutely. Conditions like heart failure with preserved ejection fraction or mitral valve disease.
Okay.
If the powerful left side of the heart gets stiff or fails, it causes a traffic jam. The blood just backs up into the lungs, raising the pressure passively.
So what happens if a doctor gets it wrong? Say they don't do the catheterization, they just guess, and they give a patient the cure for the rare lung version, those group 1 vasodilators, but the patient actually has group 2 left heart disease.
You can actively, severely harm the patient.
Really?
Yeah. This raises an important question about diagnostics, because if you give a group 1 drug, you are forcefully dilating the pulmonary vessels.
Opening the pipes wide.
Right. You are opening the floodgates and sending a massive rush of blood toward a left heart that is already stiff and failing.
Oh, no.
The left heart just can't handle the volume. The pressure spikes, and the fluid has nowhere to go but out of the blood vessels and into the air sacs of the lungs.
So you are basically flooding the lungs.
You will cause severe pulmonary edema. You are essentially drowning the patient from the inside.
Which proves exactly why a simple echocardiogram isn't enough. An echo can estimate the pressure by looking at the blood flow, but it can't confidently calculate the resistance in wood units.
Exactly.
It can't distinguish a Group 1 hose clamp problem from a Group 2 backed-up spigot problem. You absolutely need that invasive right-heart catheterization.
The echo is a fantastic screening tool to tell you there is a problem, but the catheter is the confirmation that tells you exactly how to treat it safely.
So we have seen how drugs can accidentally cause the disease. But fascinatingly, the most famous treatment for it was also discovered by total accident, revealing the strange genetic and molecular underpinnings of these vessels.
It is a crazy story. Let's start with the genetics, though.
Okay.
In the year 2000, researchers identified mutations in a gene called BMPR2 as the primary cause of heritable PAH cases.
So it's passed down.
Right, but there was a twist. The mutation has incomplete penetrance, meaning only about 20% of the people who carry the mutated gene ever actually get sick.
It's like a loaded gun, but something else has to pull the trigger.
Yes, you need a second hit, an environmental trigger, a virus, or a drug to actually start the disease process.
And on the treatment side, we have the bizarre history of sildenafil.
Oh, this is classic. In the 80s and 90s, Pfizer was developing a drug called sildenafil to treat angina, which is chest pain caused by poor blood flow in the coronary arteries. The physiological goal was to inhibit a specific enzyme called PDE5. By blocking PDE5, the drug would boost nitric oxide levels, which naturally dilate blood vessels.
But the clinical trials for angina were a total bust, weren't they?
It failed completely for angina. It just didn't dilate the heart vessels enough to make a difference.
Okay.
But the nurses running the clinical trials noticed a very specific, unexpected side effect in the male patients.
Right.
The drug was acting on the nitric oxide pathway somewhere else entirely. So in 1998, Pfizer repurposed it and it became Viagra, famously treating erectile dysfunction.
But the biology doesn't stop there, because the exact same nitric oxide pathway, regulated by that same PDE5 enzyme, also controls the smooth muscle in the pulmonary vessels.
It's all connected, so researchers tested it again, this time on pulmonary hypertension patients, and it worked beautifully to relax those lung vessels. In 2005, it was approved under the brand name Revascio, specifically to treat pulmonary arterial hypertension.
That is wild. One single biological pathway. 3 completely different medical stories. It flopped as a heart condition drug, became a blockbuster lifestyle drug, and then evolved into a cornerstone, life-saving therapy for a rare lung heart disease.
It really shows you how versatile these molecular pathways are.
So what does this all mean for a patient today? It shows how incredibly interconnected our biology is. Today, the sources show us there are 3 main dysregulated pathways driving the constriction in PAH.
Right, 3 main targets.
There's idaphyllin-1, which is a powerful vasoconstrictor that becomes dangerously overactive. There is the nitric oxide pathway we just discussed, which is underactive, and prostacyclin, another natural vasodilator that is also underactive.
And modern, highly expensive drugs are engineered to target those 3 specific pathways.
But not everyone needs those expensive drugs, right?
Interestingly, no. Only about 10% of patients are deemed vasoreactive during their catheterization.
What does that mean?
For that lucky 10%, their vessels respond so well to basic relaxation that they can just take standard, cheap calcium channel blockers.
Oh, wow.
Yeah, since calcium is the mineral that tells muscles to contract, blocking it simply keeps the lung vessels relaxed.
If we connect this to the bigger picture, pulmonary hypertension is the ultimate systems biology disease. You just cannot understand it by looking at a lung x-ray.
Not at all.
You have to look at genetics, environmental triggers like high altitude, the pharmacology of serotonin, and the distinct vulnerable mechanics of the right ventricle all at the same exact time.
It genuinely requires a holistic view of human physiology.
Let's quickly recap this incredible journey for you. Pulmonary hypertension is a moving target of a definition, recently shifting from 25 down to 20 millimeters of mercury.
Right.
It has been historically triggered by diet drugs, driven by 3 tiny molecular pathways, and ultimately it is the story of a hidden lung disease that mechanically breaks the right side of the heart.
And remember why this matters today. I mean, it is not just historical trivia. We are actively seeing right heart strain in critical illnesses like severe COVID-19. And we are seeing rising rates of obesity and sleep apnea driving chronic hypoxic pressure in the lungs of millions of people.
And crucially, we are currently seeing a massive boom in new weight loss drugs, which, given the institutional memory of the Aminorex and Fen-Phen disasters we talked about, are facing intense scrutiny.
The ghosts of those past pharmacological disasters still heavily haunt this field.
Which leaves us with a provocative final thought.
Consider this landscape. The newer weight loss drugs are scrutinized heavily because past diet drugs chemically triggered this deadly pulmonary disease.
Right, there is that historical fear.
Yet, the obesity and sleep apnea that those new drugs treat are themselves massive physiological drivers of pulmonary hypertension today.
It is a total catch-22.
It is. Are we caught in a strange medical paradox where the potential chemical triggers for this disease and the potential cures for its root causes are locked in a biological tug-of-war?
That is absolutely something to mull over. We started today by talking about the silent pressure gauge, hidden in the chest, a tiny shift in millimeters of mercury that forces a thin-walled heart to fight against a brick wall.
It's an invisible battle.
It turns out that invisible plumbing system holds some of the most dramatic stories of adaptation and consequence in medical history. Thank you for joining us on this deep dive, and stay curious.